in Department of Cardiac Surgical Oncology, Mullanpur, Tata Memorial Center, Chandigarh. He will be talking on the applied anatomy of larynx and hypopharynx. So I welcome Dr. Shikhar to please start with the presentation.
Good morning, ma'am. Thank you for this introduction. So I'll be sharing my screen now. Should I start?
Please, yes, please, Shikhar.
Yes, ma'am. Good morning, everyone. Is my screen visible? Hello?
Yes, it is
Your
visible.
screen is visible, Shikhar. Please continue.
Okay. Good morning, everyone. So the topic of my presentation is applied anatomy of larynx and hypopharynx. I'll be talking about the salient anatomical features of this organ while focusing more on the clinical aspects of it, which I'll be highlighting along the way. I won't be going too much into the nitty-gritties of the anatomy, as that will be beyond the scope of this talk. So starting with the larynx, it forms the upper part of the airway opposite C4, C5, and C6 vertebra. It forms the serves the triple function of being the gateway to the airway. It is the most Hello? Yeah. Am I unmuted now?
Yes, Shikhar. Please continue.
Yeah. So as I was saying, it serves the triple function of being the gateway to the airway. It is responsible for phonation, and it also is responsible in the deglutition process. The position of this larynx varies with the movements of the neck. On extension, it moves up. And this is important clinically because almost all neck surgeries are done in this extended position of the neck, which brings the larynx and the thyroid in a superficial position. While flexing the neck will cause the larynx to go into a posterior inferior direction, and that is clinically important because when we are doing direct laryngoscopies or difficult microlaryngoscopies, we want the airway and the larynx to be in direct line with the oral cavity so that we get a better visual access to it. Now, as we all know, larynx has three subsites: the supraglottis, glottis, and the subglottis. Now, these are divided not just anatomically, but they also have a different embryological basis to it. The presentation of the tumors in these three different subsites behaves differently. The clinical behavior is also different, as well as the patterns of spread. Starting with the supraglottis, as the name suggests, it connects the base of tongue to the larynx, and it forms the superior part of the larynx above the vocal cords. Its subdivisions includes the laryngeal surface of the epiglottis, the aryepiglottic folds, the arytenoids, false cords, and inferiorly it is bound by the ventricles, which is the space between the true cords and the false cords. Now, this part of the larynx is richly innervated by the lymphatics, and the tumors in this area through the thyrohyoid membrane track along the superior thyroid pedicle and gain access to the level 2 and level 3 cervical lymph nodes. Moving on to the most important part of the supraglottis, the most prominent part of the supraglottis, that is the epiglottic cartilage. It is a leaf-shaped fibrocartilage which has a superior free edge, and inferiorly it has a narrow petiole through which it is attached to the thyroid cartilage. On the sides, it is connected to the arytenoids by the aryepiglottic folds. Now, it has two parts. The superior part is the suprahyoid part, and the inferior part is the infrahyoid part. These are divided by the hyoepiglottic ligament, which is a ligament that runs anteroposteriorly from the hyoid bone towards the lingual surface of the epiglottis. The epiglottis has numerous pits and numerous holes in its surface, through which the tumors in the supraglottic region can communicate with the pre-epiglottic space that is present just anteriorly. And that again results in an early lymphatic spread in these tumors. Moving on to the glottis, it has three subdivisions: the true conch, the anterior commissure, and the posterior commissure. The rima glottidis is the glottic aperture between the free edge of the true vocal cords, and its shape obviously varies by whether the cords are in the adducted or the abducted position. Inferiorly, glottis extends till 1 centimeter below the free margin of the true vocal cords. Now, this area is distinct or different from the supraglottis in the fact that the lymphatics in this area are very sparse. So tumors limited to the glottic area usually do not present with lymphatic metastasis. Talking in detail about the true vocal cord, it is again subdivided into the anterior 2/3, which is the membranous part. The posterior 1/3 part of the true vocal cord is cartilaginous, as it is formed by the vocal process of the arytenoids. The two true vocal cords meet anteriorly in the midline to form the anterior commissure. The two vocal ligaments from the two vocal cords blend with the perichondrium of the thyroid cartilage in this area to form what is known as the Broyles ligament. Now, this has immense clinical significance as tumors in the anterior commissure gain direct access to the thyroid cartilage through the Broyles ligament and can spread extralaryngeally through this pathway. Posterior commissure refers to the loose mucosa that is present on the anterior surface of the arytenoids, as well as the vocal process of the arytenoids. This is clinically significant because any trauma or any trauma due to intubation or due to external trauma may lead to scarring in this area, and that would prevent abduction of the cords. And this condition mimics a bilateral abductor cord palsy, and this needs to be kept in mind. Talking about the microanatomy of true vocal cords, now these true vocal cords are layered structures. They have 5 layers to them. The superficial most layer is formed by the squamous epithelium. Deep to it is the lamina propria, which is again divided into the superficial layer, intermediate layer, and the deep layer. And the deepmost part is the thyroarytenoid muscle or the vocalis muscle. The superficial layer of lamina propria consists of elastins and collagen fibrils, which are arranged in a loose manner. Whereas in the intermediate and the deep layer, these collagen and elastin fibrils are more densely packed. The intermediate and the deep layer together form what is known as the vocal ligament. And the 3 deep layers, that is the intermediate layer of the lamina propria, the deep layer of the lamina propria, and the vocalis muscle together form the body of the vocal cord. Whereas the 2 superficial layers, the SLP, the superficial lamina propria, as well as the squamous epithelium, form the cover of the vocal cords. Together, this is called as the body cover model of the vocal cords. This is important. Knowing about all this is important because based on this microanatomy, the European Laryngology Society has classified different types of cordectomies based on what layers of vocal cords are being removed. As we go progressively deeper into the vocal cord, into the layers of the vocal cords, the types of the cordectomies increase from type 1 to type 5. Moving on to subglottis. Now, this is the area, as the name suggests, below the free edge of the vocal cord. It begins from 1 centimeter below the free edge of the vocal cords to the inferior part of the cricoid cartilage. This area of the airway is prone to stenosis, and is the most common area of airway stenosis following trauma or prolonged intubation or even incorrect maneuvers. And that happens because these maneuvers can ulcerate the mucosa, leading to exposure of the cricoid cartilage, and that can lead to scarring and stenosis. Lymphatics from this area drain to level 6 and the paratracheal lymph nodes. Now, let's talk about the laryngeal framework. It consists of the skeletal framework, that is the cartilage and the bones, followed by muscles of the larynx. The laryngeal framework is interconnected to each other by the soft tissues of the larynx. And finally, we'll talk about the potential spaces that the larynx has. So larynx is formed by the hyoid bone and 3 paired and 3 unpaired cartilages. The hyoid bone is located in the superior part of the larynx, and from this, the rest of the larynx is suspended into the neck. This hyoid bone has a greater horn and the lesser horn, and it provides attachment to various suprahyoid and infrahyoid musculature. The cartilages, the 3 paired cartilages include the arytenoid cartilages, the corniculate and the cuneiform cartilages, while the 3 unpaired cartilages include the epiglottis, the thyroid, and the cricoid cartilage. Talking about the most prominent and the most important cartilage of the laryngeal framework, that is the thyroid cartilage. It has two lamina. And a superior cornu and the inferior cornu. The two lamina fuse anteriorly at the laryngeal prominence, making an angle of 90 to 120 degrees, depending on whether it is a male or a female. Now, this angle is important because in laryngeal cancers, this angle tends to become more obtuse, a phenomenon that is called as laryngeal widening, which is an important sign of laryngeal cancer. The superior cornu goes superiorly and gets attached to the greater horn of the hyoid by the thyrohyoid ligament. And this is an important landmark because it is in close proximity to the superior laryngeal neurovascular bundle, which needs to be looked at in conservation laryngeal surgeries. The inferior cornu, as the name suggests, goes inferiorly and forms a synovial joint with the cricoid cartilage called the cricothyroid joint. That is again of immense clinical importance because it is in close proximity to the recurrent laryngeal nerve that is again should be preserved in conservation laryngeal surgeries. The lamina of the thyroid cartilage has an oblique line which serves as attachment of the inferior constrictors. While performing a laryngectomy, the constrictors are cut at this level of oblique line and then reflected posteriorly to expose the pyriform mucosa. Relationship of the internal laryngeal structures to the surface marking of the thyroid cartilage is very important in surgeries like thyroplasties and open supraglottic laryngectomies, as we need to make the plan and make the cartilaginous cuts at the exact level of the paraglottis and the glottic area. So this knowledge is of immense importance. The cricoid cartilage located below the thyroid cartilage is a signet ring-shaped cartilage. It is the only structure that is a complete ring in the entire airway, thus provides stability to it. The peculiarity of this cartilage is that anteriorly, the arch is narrow. It is just 5 to 7 millimeters, whereas posteriorly, the cricoid plate is broad. It has which measuring 2 to 3 centimeters. This is important in supracricoid partial laryngectomies because tumors that are going into the subglottis in the anterior part, even if they go till about 1 centimeters deep to the glottis, may still be amenable for a supracricoid partial laryngectomy. Whereas posterior subglottic tumors, even if they track just 5 millimeters below the subglottis, will reach the cricoid cartilage because this cricoid plate is broad posteriorly and hence might not be amenable for a supracricoid partial laryngectomy. Then the cricoid is attached to the thyroid cartilage anteriorly by the cricothyroid membrane. This is the most superficial part of the airway, and that is important because in emergency surgeries, we can perform a cricothyroidotomy in this membrane. Posteriorly, the cricoid is attached to the thyroid by the cricothyroid joints bilaterally. And as I mentioned, they are in close proximity to the recurrent laryngeal nerves, which is important when we are performing conservation laryngeal surgery, especially supracricoid. Talking about the arytenoid cartilages, these are pyramid-shaped cartilages located on top of the cricoid cartilage. The base articulates with the cricoid cartilage, whereas the apex of these cartilages articulates with the corniculate cartilages, which are located just above the arytenoid cartilage. It has two processes: the vocal process, which attaches to the vocal ligament anteriorly, and the muscular process, which provides attachment to the cricoarytenoid muscles laterally and posteriorly. And this is responsible for the adduction and abduction of the vocal cords. Now, what is important here is that the arytenoid cartilages, along with the cricoid cartilages, form the cricoarytenoid joint and are part of the cricoarytenoid unit, which is extremely important as at least one of this cricoarytenoid unit needs to be preserved in conservation laryngeal surgeries, and that is it is a prerequisite to perform a conservation laryngeal surgery. Talking about the laryngeal muscles, they can be divided into intrinsic and extrinsic muscles. As the name suggests, intrinsic muscles are those which have their origin and their insertion within the laryngeal framework, whereas the extrinsic muscles are those which either originate or who insert outside the laryngeal framework. And they are responsible primarily for the movement of the larynx superior, inferiorly, or anteriorly, whereas the intrinsic muscles, the various intrinsic muscles that we have, act synergistically and in coordination with each other to perform the roles of phonation, cough reflex, and the sphincter mechanism. Talking very briefly about the intrinsic muscles and the clinical importance that they have. The cricothyroid muscle, as the name suggests, begins from the cricoid cartilage and inserts onto the posterior part of the thyroid lamina. By altering the distance between the cricoid and the thyroid cartilage, it lengthens or shortens the vocal cord and thus is responsible for the pitch of our voice. And it is a tensor of the vocal cord. The posterior cricoarytenoid muscle is important as it is the only abductor of the vocal cord, whereas the lateral cricoarytenoid, the aryepiglottic muscle, and the thyroarytenoid muscles are the adductors of the vocal cords. These muscles, in addition with being the adductors, are also the laryngeal inlet modifiers, and they open and close the laryngeal inlet as the need may be. What is important here is that all intrinsic muscles are supplied by the recurrent laryngeal nerve, except the cricothyroid muscle, which is supplied by the external branch of the superior laryngeal nerve. So if there is recurrent laryngeal nerve palsy, the cord assumes a median or a paramedian position, and it is primarily because of unopposed action of the cricothyroid muscle, as it is a tensor of the vocal cord, and it brings the cords in a median or a paramedian position because of its unopposed action. Extrinsic muscles, as I already mentioned, are responsible for the superior, inferior, and the anterior movement of the larynx. They may elevate the larynx or depress the larynx, depending on where they take their origin and where they insert. And they are responsible, and they are important in the second and the third phases of swallowing mechanisms. Moving on to the soft tissues of the larynx, the laryngeal framework, that is the cartilage and the bones, are connected to each other by the ligaments and the various fibrous membranes. They are also divided into intrinsic and extrinsic soft tissues. The intrinsic soft tissues include the quadrangular membrane, the conus elasticus, and the hyoepiglottic ligament. Whereas the extrinsic muscles include the thyrohyoid membrane, the cricothyroid membrane, and the cricotracheal membrane. Knowing about this is important, as these soft tissues form natural barriers to check cancer spread, and their knowledge of anatomy is important in predicting the tumor spread. Talking about the quadrangular membrane and conus elasticus, quadrangular membrane is the natural barrier to tumor spread in the supraglottis. Looking at this coronal section of the larynx, this blue structure here is the quadrangular membrane. As we can see, it is medially related to the loose mucosa of the supraglottis. Laterally, it is related to the paraglottic space. Anteriorly, it extends from the lateral edge of the epiglottis, and posteriorly, it goes on till the arytenoids. Inferior part of this quadrangular membrane thickens and forms what is known as the vestibular ligament and forms the false vocal cords. The conus elasticus is the natural barrier in the glottis and the subglottis region inferiorly. In this diagram here, this structure is the conus elasticus. Now, looking at the relations, inferiorly, it attaches to the cricoid cartilage. Superiorly, it goes on, and the superior part of it thickens to form what is known as the vocal ligament and forms the true vocal cords. Anteriorly, it tracks along the vocal ligament and is attached to the thyroid cartilage in the median cricothyroid ligament, and posteriorly, it goes on till the vocal process of the arytenoids. Laterally, it is again related to the paraglottic space. Extrinsic ligaments are pretty self-explanatory. The thyrohyoid membrane goes from the hyoid bone till the thyroid cartilage. It is a natural barrier again in the supraglottis. The superior laryngeal neurovascular bundle pierces this thyrohyoid membrane, and this is of clinical importance here, as the disease in the supraglottis may track along this neurovascular bundle towards the carotid bulb or the level 2 region. The cricothyroid membrane, as the name suggests, tracks from the cricoid to the thyroid cartilage. Inferiorly, in the midline, it thickens to form the median cricothyroid ligament, whereas laterally, it thickens to form the lateral cricothyroid ligament. It is the natural barrier in the subglottis area, and as I mentioned before, cricothyroidotomy is performed in this area. The cricotracheal membrane is, again, as the name suggests, goes from the cricoid cartilage to the first tracheal ring. Now, the anatomy of larynx is pretty unique in the sense that it has various potential spaces, and the larynx is compartmentalized into different spaces by virtue of their different embryological development. And these potential spaces act as barriers for early cancer spread. However, once the cancer progresses and goes beyond these potential spaces, it tracks along the paths of least resistance. These potential spaces form the basis for our conservation laryngeal surgeries. Now, our knowledge of these potential spaces comes from the dye studies that were done by Pressman in as early as in 1956. What he did was that he injected dyes into specific areas of the larynx using a laryngoscope, and then they performed the laryngectomy. The specimen was then studied to see the distribution of the dye, and what they saw was that the dye was limited to specific well-defined compartments only. And this formed the understanding of different potential spaces in the larynx, and which may be influencing the tumor spread. Talking about these spaces, the first space is the Reinke space. As I already mentioned, it is the part of the superficial lamina propria of the true vocal cord. It is a submucosal space that is present along most of the length of true vocal cords. It allows the mucosa over it to slide and vibrate and form the mucosal wave, which is important for good phonation to happen. Now, this has two huge clinical implications. One is that very early glottic cancers may be amenable for a type 1 chordectomy, that is a subepithelial chordectomy, in which this space, that is the superficial lamina propria, is preserved, and this leads to very good voice outcomes even after a microlaryngeal surgery. The second important clinical implication is that sometimes in this space there is fluid accumulation, and that leads to baggy vocal cords, which a condition that is known as Reinke's edema. The next important space is the pre-epiglottic space of Boyer. In this sagittal section, we can appreciate it is a fat-filled space superiorly bound by the hyoepiglottic ligament, anteriorly bound by the thyroid membrane and the superior part of the thyroid cartilage. Inferiorly, it is limited by the petiole of the epiglottis and the thyroepiglottic ligament. Posteriorly, it is limited by the infrahyoid epiglottis. And laterally, it communicates with bilateral paraglottic spaces. The paraglottic space is the space between the glottic mucosa and the thyroid cartilage. If we look at this coronal section, we'll be able to understand it better. It consists of the vocalis muscle. So to understand its relations, going from superior to inferior, medially, it is bound by the quadrangular membrane superiorly, then the vestibular fold and the ventricle, and inferiorly by the conus elasticus. Laterally, it is bounded by the thyroid cartilage. Superiorly, it is bound by the aryepiglottic folds, and inferiorly, it is limited by the conus elasticus. Anteriorly, it is again communicating with the pre-epiglottic space. This is an oblique view of the larynx, wherein we can appreciate the communication between the pre-epiglottic space and the paraglottic space. The yellow part is the pre-epiglottic space, and as we can see on either side of the epiglottis, laterally, it communicates with the green and the red zones, which are the paraglottic spaces. What is the clinical significance of these spaces? Involvement of these spaces upstages the tumor directly to T3. Frank involvement of pre-epiglottic space precludes any conservation laryngeal surgeries, as it would necessitate removal of the hyoid bone as well, and we wouldn't have anything to anastomose the remnant larynx with. Involvement of the pre-epiglottic space also leads to exolaryngeal spread through the superior laryngeal neurovascular bundle, as I already mentioned, through the thyroid membrane. Even the paraglottic space would preclude an exolaryngeal spread inferolaterally, because that communicates with the gap between the thyroid and the cricoid cartilage. Also, a frank paraglottic space involvement would lead to vocalis muscle involvement, and that would lead to vocal cord fixity as well. Spread along these two spaces would lead to a transglottic spread of tumor as well. So knowing about these two spaces is extremely important while making clinical decisions. The larynx is innervated mainly by the superior laryngeal and the recurrent laryngeal nerves. As we can see here, the superior laryngeal nerve divides into the internal branch, which is responsible for the sensory supply of the larynx above the level of vocal cords, and the external branch of superior laryngeal nerve, which courses along the inferior constrictor and innervates the cricothyroid muscle. The recurrent laryngeal nerve comes from below, and it has both a sensory and a motor component as well. The sensory component innervates the larynx below the level of vocal cords, whereas the motor branch innervates all muscles of the larynx, intrinsic muscles of the larynx, except the cricothyroid muscle. The clinical importance of this knowledge is that in conservation laryngeal surgeries, it is important to preserve this nerve, that is the internal branch of the superior laryngeal nerve, maintains, that would prevent aspiration of these patients in the post-op period. Moving on to the applied anatomy of hypopharynx, it is a 5 centimeter long funnel-shaped tube that extends superiorly from the hyoid bone and inferiorly till the lower border of cricoid. It is communicating superiorly with the oropharynx and inferiorly with the esophagus. It has 3 subsites: the pyriform sinus, the postcricoid, and the posterior pharyngeal wall. In this axial section, rather in this direct laryngoscopy view, we can appreciate the 3 components of the hypopharynx. This is the endolaryngeal area. Posterior to it is the hypopharynx. This is the area of the pyriform sinus, which communicates laterally with the posterior pharyngeal wall and posteriorly with the posterior pharyngeal wall, and medially with the postcricoid area. Talking about the pyriform sinus, it extends. If you look at this figure, this is the area of the pyriform sinus. It extends superiorly from the pharyngoepiglottic fold and inferiorly till the upper end of the esophagus. It has 3 parts: the medial wall, which is bounded by the hypopharyngeal surface of the arytenoid and the aryepiglottic folds; the lateral wall, which is bounded by the thyroid cartilage; and the apex, which is the narrow converging area towards the cricopharynx. The other subsites are the posterior pharyngeal wall, which area from the hyoid till the inferior border of the arytenoid, and laterally from the apex of one pyriform sinus to the other. Postcricoid area, as the name suggests, refers to the mucosa behind the cricoid cartilage, and it extends from the arytenoid cartilages superiorly till the inferior border of the cricoid. It forms the anterior wall of the hypopharynx, and inferiorly it continues into the cricopharynx. Now, the whole purpose of knowing this anatomy, because knowing knowledge of the roots of spread of the tumor, and that would so let us look at the roots of spread of laryngeal and hypopharyngeal cancers. Talking about the glottic cancers first, they are usually slow growing and have a predictable route of spread. They may spread in the glottic plane, that is the anteroposterior plane, or they may track superiorly or inferiorly through the anterior commissure to the petiole of the epiglottis superiorly or to the subglottic area inferiorly. They may also go laterally in a deep plane and involve the paraglottic space and the vocalis muscle. Now, important here to note is that once the tumor goes to the anterior commissure area, it becomes a little notorious because we may clinically feel that it is a mucosal anterior commissure tumor. However, because the anterior commissure tumors are in close proximity to the Broyles ligament, tracking through the Broyles ligament, they can involve the thyroid cartilage at an early stage, and what we think is a mucosal T1 tumor might actually be a T4 tumor causing erosion of the thyroid cartilage anteriorly. Supraglottic tumors usually remain localized to the supraglottic subsites, and that is because of the natural barriers that are present in the supraglottis which prevent its spread to the glottic area. They may go anteriorly into the pre-epiglottic space through the holes in the epiglottis. They may also go into the paraglottic space once the pre-epiglottic space is breached, as the 2 spaces are connected. Once these 2 spaces are cartilage erosions as well. And supraglottic tumors are notorious in the sense that they are 2 and 3. To give you glottic tumor, the petiole of the epiglottis and go into the pre-epiglottic space. It may grow laterally to involve the aryepiglottic fold and the paraglottic space. It may grow posteriorly and involve the arytenoid as well. However, its extension into the glottic area would be a little late because, as I said, because of the natural barriers present in the supraglottis. Now, what are marginal zone tumors? Marginal zone refers to the area of aryepiglottic folds and the arytenoids. As the name suggests, these are present at the margin of the supraglottis and the hypopharynx. Because of its close proximity to both these areas, it has a tendency to spread posteriorly to the pyriform sinus and the postcricoid area, and medially also to the supraglottis and the false chord area. This area has rich lymphoid tissue in its submucosa, therefore is prone for early lymphatic spread as well. Talking about subglottic cancers per se are rare. Usually, it is a subglottic extension of glottic cancers that we usually see. They usually spread circumferentially in the subglottic area. They have an early exolaryngeal spread through the cricothyroid membrane. And also because of its close proximity to the thyroid gland, they may spread to the thyroid gland. They may involve the thyroid gland at an early stage of the disease as well. The lymphatic drainage of this area is to the pretracheal and the level 6 nodes. Importance of these subglottic cancers are because of its close proximity to the cricoid cartilage, they are absolutely not candidates for any sort of conservation laryngeal surgeries. Looking at pyriform sinus tumors, talking about the medial wall of pyriform sinus tumors first, they behave exactly like the marginal zone tumors. They may grow medially and involve the aryepiglottic folds and the paraglottis. They may grow posteriorly and involve the post-cricoid area. Whereas the lateral wall of pyriform sinus tumors, as we can see in this graphic, because of its close proximity to the thyroid cartilage, they may cause an early exolaryngeal spread either through the thyroid cartilage or posterior to it, and thus may even invade the carotid sheath laterally. Superiorly, these pyriform sinus tumors, the lateral pharyngeal wall, and they may grow towards the tonsil and the tongue base as well. This is another graphic explaining the routes of cancer spread of pyriform sinus tumors in various directions. So if you look at this tumor in the pyriform sinus has access and space laterally, exolaryngally, and to the carotid sheath, and posteriorly and posteromedially to the cricoid space, post-cricoid area as well. Now, what about pyriform sinus apex tumors? These are, again, bad tumors to have. This is a section of the larynx at the level of true vocal cords. Now, imagine a tumor here in the pyriform sinus apex area. This tumor can very easily invade medially and involve the cricoarytenoid joint. It may grow laterally along the muscular wall of the inferior constrictors and gain access to the posterior part of the thyroid cartilage and cause its cartilage erosion. It may also grow anteriorly towards the paraglottic space and fix the cord. Importance of this pyriform sinus apex region is that, again, no conservation laryngeal surgery is possible if the PFS apex is involved, as it is very close to the cricoarytenoid joint and the cricoid cartilage. Post-cricoid cancers, again, are very bad cancers to have. These are two sections. This is a section of the larynx through the mid-post-cricoid area, and this is a section inferior, just inferior to it, in the inferior part of the post-cricoid area. So imagine a tumor here. This is the cricoid cartilage. Imagine a tumor in the post-cricoid area here. It can grow anteriorly and involve the party wall between the trachea and the esophagus. It can grow laterally and straight away involve the thyroid gland and the recurrent laryngeal nerve as well, and may even cause bilateral recurrent laryngeal nerve palsy. Posteriorly, these tumors can go into the prevertebral fascia and may lead to clinically called as the Boca's sign. They may track submucosally into the cervical. The importance of these post-cricoid cancers is, apart from the various neighboring structures that it can invade, it also has a tendency for submucosal spread. So the margins when excising such tumors should be sufficiently wide. The lymphatic spread from these cancers goes primarily to level 6 before going into the lateral compartment. Posterior pharyngeal wall tumors, again, may grow posteriorly and involve the prevertebral fascia. They may grow along the posterior pharyngeal wall in its entirety, or may even grow towards the lateral wall of the pyriform sinus. Lymphatically, it is important that the involvement of the retro needs to be clinical. Now, we all know why tumors to have compared to laryngeal different. The answer again lies in the hypopharyngeal cancers in the submucosa have rich lymphatics. Therefore, there is early lymphatic spread of these. They also have a large amount of submucosal spread and the tumors tend to spread along the muscular walls of the hypopharynx. And lastly, the most important point is that there are no natural barriers present in the hypopharynx like we have in the larynx. So there are no checkpoints to tumor spread, which results in these tumors being detected at an advanced stage, compromising survival. Now we know we have looked at the anatomy, we've looked at the potential spreads of tumor. Now let us put this knowledge of anatomy and the potential tumor spreads to clinical decision making. This is the view that we get when we do this slide, so that the next time you all do a direct laryngoscopy, you all should know that involvement of each subsite has its own clinical importance, and that needs to be taken into account when you make your surgical decisions based on your direct laryngoscopy. So let's see how that happens. If a tumor is located in the endolaryngeal, if we are considering a total laryngectomy, tumors limited to the endolaryngeal area may very well be amenable for a primary closure of the larynx after the laryngectomy is done. If it is a small volume disease, these tumors may also be considered for conservation laryngeal surgeries, depending, of course, on the extent of these tumors. If there is a tumor located in the supraglottic area, or if there is a supraglottic disease, if it is a small volume disease, the pre-epiglottic space is free, these tumors may be amenable for a transoral laryngeal microsurgery or an open supraglottic laryngectomy. Involvement of if there is a disease which is tracking superiorly and going up to the vallicula, if only the ipsilateral vallicula is involved, these tumors are still resectable. However, if bilateral vallicula is involved and the tumors are crossing the midline in the vallicula, a lot of caution, because these tumors, the bilateral lingual arteries will be at risk, and laryngectomy along with a total and that is a very morbid surgery, and that is usually not done. If the tumor is located in the wall of the small volume disease, it can be small proliferative disease, it may be amenable for a transoral laryngeal microsurgery. If, however, it is a large volume disease that is involving the medial wall of the pyriform sinus, primary closure of the remnant laryngeal mucosa may still be amenable, may still be possible. However, if the lateral wall of pyriform sinus is involved, the primary closure most of the times would not be possible, and it would need some sort of pharyngeal reconstruction in the form of patch pharyngoplasties. If, however, it is a small volume disease only limited to the lateral wall of pyriform sinus, it may be amenable for a surgical excision by a pharyngotomy approach. Moving on to PFS apex. Now, as I already mentioned, no conservation surgery is involved once the PFS apex is involved. Also, if the apex is involved, some sort of pharyngeal reconstruction would definitely be needed, and you will not have enough mucosa to close the larynx primarily. If the post-cricoid area is involved, again, you're looking at some form of patch pharyngoplasties, but it may also result in a circumferential resection. So the option of a circumferential reconstruction in the form of rejejunum should also be kept as a standby. And the same goes for posterior pharyngeal wall tumors, which would definitely need either a patch pharyngoplasty or, more often than not, a circumferential resection. So to conclude, larynx and hypopharynx have a complex and intricate anatomy. They are compartmentalized into well-defined compartments and natural barriers due to their different tumors of different subsites behave differently with regards to local as well as regional spread to the lymphatics, and detailed knowledge of all these various subunits and these potential spaces and various compartments is necessary to predict the pathways of spread and hence plan the manage accordingly. Thank you very much.
So thank you, Dr. Shikhar. It was actually a wonderful presentation. I think there are two questions mostly on the chat. I would request if you could take them.
Yes. So the first question that I'm seeing is importance of intrinsic ligaments in thyroplasty surgery. So in thyroplasty surgeries, what is important to note is that we should know the surface markings and the surface relations of the thyroid cartilage with the internal laryngeal structures. So we should know the exact location of where the vocal cord is, where the paraglottic space is. Intrinsic ligaments like the quadrangular membrane and the conus elasticus are not of prime importance when we are doing a thyroplasty surgery per se. Definition of a transglottic tumor. So transglottic tumor, as the name suggests, are primarily refers to tumors that are present in that tumors that encompass the glottic as well as the supraglottic regions. They are usually, by definition, they track along the submucosal spaces and the paraglottic and the pre-epiglottic space, and they lift the mucosa submucosally rather than tracking along the mucosa. So that is the definition of a transglottic tumor. It immediately stages the tumor to at least T3, and that needs to be taken into account when making clinical decisions. The next question are the theories of phonation. So phonation happens when, as I mentioned in my the slides regarding the microanatomy of the true vocal cords, it has a body cover model. So the body of the vocal cord is formed by the vocalis muscle and the intermediate and the deep parts of the lamina propria, whereas the cover is formed by the epithelium and the superficial lamina propria. So what happens is when we phonate, there is a mucosal wave that happens, and that happens because the superficial layers, the cover of the vocal cord, that is the epithelium and the superficial lamina propria, move freely over the body of the vocal cord, and that is responsible for making the mucosal wave, and that leads to adequate phonation. If there is some sort of scarring or there is some sort of surgery because of microlaryngeal surgeries that we do, this mucosal wave is inhibited because we are operating on the mucosa and the superficial lamina propria of the vocal cord, and that leads to inferior voice outcomes. That would be all the questions. Somebody wants to see the first 5 slides. I'll share my screen again.
Shikhar, we will be anyways putting this on our YouTube channel.
Okay,
and this will be available. So we'll try to put it on the channel in subsequent week, and it will be freely available to everyone.
Right, ma'am.
If any other question to Dr. Shikhar from anyone, they can ask directly also.
Thank you, Asiya. Position of external and internal laryngeal nerves with respect to the cricoid cartilage. Okay, so the external laryngeal nerves is, I'll try to explain this by showing you that diagram again. It will be easier for you to understand. Yeah. One second. So if we go, yeah. So if you look at this slide, the superior laryngeal nerve divides into the internal laryngeal nerve and the external branch of the superior laryngeal nerve at the level of the hyoid, just below nodose ganglion. The internal branch of the does not have any relation with the cricoid, as it enters the larynx directly through the thyrohyoid membrane and then innervates the supraglottic larynx and is responsible for the sensory supply. Now, the external branch of the superior laryngeal nerve goes along the inferior constrictor muscle, along the posterior lamina of thyroid cartilage, and then inserts onto the cricothyroid muscle. So, and as we know, the cricothyroid muscle takes origin from the cricoid cartilage and goes on to the posterior part of the thyroid cartilage. So the external branch of superior laryngeal nerve is what is important and what is in relation to the cricoid cartilage. This nerve is also seen when we do thyroid surgeries, and when ligating the superior pole. This is the branch that we need to preserve so as to preserve the innervation to the cricothyroid muscle, because that would enable that the patient has adequate pitch even after surgery. Does that answer your question?
So I think someone has raised the hand. If someone wants to ask the question, please ask it. because we'll be concluding in a minute.
What is epilarynx? Epilarynx refers to supraglottic larynx only.
Yes, Jiten, ask.
Good morning, Dr. Actually, what I want to ask is about the role of Broyles ligament actually, because in literature, whatever I have read, the role of Broyles ligament in the spread of tumor measure to thyroid cartilage is controversial.
Right.
Right. So whether we can do a TLM surgery, laser microsurgery in anterior commissure involvement or not, that is still a very controversial issue.
Right.
So what is your point on that?
Yeah. So this ligament is that vocal ligaments, they converge onto the anterior commissure, fuse together, and go towards the perichondrium of the thyroid cartilage anteriorly, and are connected to the thyroid cartilage anteriorly through this ligament, that is the Broyles ligament. Now, its clinical significance is that anterior commissure tumors have a potential route of spread through the Broyles ligament, and they have an easy access to the thyroid cartilage anteriorly. Now, what you mentioned as regarding the controversy of anterior commissure of Broyles ligament, you will find in the literature, you will find that at some places it is mentioned that Broyles ligament will serve as a pathway of spread of tumor towards the thyroid cartilage, whereas at some places it is also mentioned that the Broyles ligament will in fact prevent tumor spread to the thyroid cartilage. Now, what usually happens is that anterior commissure tumors through the Broyles ligament go towards because they have an easy access to the thyroid cartilage, and not just the thyroid cartilage, through the Broyles ligament, they can go superiorly to the petiole of the epiglottis as well as inferiorly into the subglottis, and that leads to upstaging of the tumor. So what clinically we might feel that the tumor is an anterior commissure tumor is a mucosal lesion, and it is probably a T1B tumor. When we study the imaging more seriously and more carefully, we can in fact see that there is early cartilage erosion in that area of the Broyles ligament, and or maybe even subglottic spread of tumor along the Broyles ligament and along the thyroid cartilage, and causing minute exolaryngeal spread. So what we think is a T1 tumor might actually be a T4 tumor, and that is the clinical importance of anterior commissure tumors and the Broyles ligament, and that is the precise reason why when doing a once the tumor, you have to be extremely careful, and you need to have sufficient expertise in dealing with these tumors when we are doing a microlaryngeal surgery for these anterior commissure lesions.
Yeah, thank you, Dr.
So thank you for this today, and I think everyone has, in fact, all of us, Shikhar, and today's presentation, and we would request you in future also to take classes for our students.
Definitely for the opportunity. Bye-bye.
Yeah,